problem, joint problem. Okay, so you you asking the patient. So that test will be like this: you asking the patient to rotate and extend. Yeah, rotate and extend. So what happened during this maneuver? Rotate and extend. Okay, if I'm doing on the right side, I rotate to the right and extend to the right. So I put a lot of pressure on the facet on this side. Okay, and also I narrow the foramen. Okay, and then also I put a lot of pressure on the disc on this side. Normally, there's no pain. Okay, if you guys do this and you feel it hurt here, localized pain, that means indicate you have some facet joint syndrome. Yeah, maybe you have some degenerative, some arthritis in the facet joint. Okay, or if I'm doing this and I have the numbness go down to my hand to my finger, that is the nerve root problem. Yeah, you might have some cervical foraminal encroachment. Yeah, so this is review. Okay, this is we learned in the previous class already. So the test, the first one, the maximal foraminal compression test. So you ask the patient to do this: rotate and extend. Okay, rotate and extend. So what are you looking for? Numbness. Pain, numbness. Yeah. If patient doing this and say, oh, you know, I have a kind of tingling numbness down to my hand to my finger. So that's the indicate for nerve root problem. Yeah. But if I'm doing this and I have localized pain here, this side, that's probably the facet joint syndrome. Okay. If I'm doing this and it hurt me on this side, that's probably the muscle problem. You see that? Okay, and oh, by the way, that's another test. O'Donnell's maneuver. I forgot that test. No, I might misspell it. Okay, you guys can check it out. Check it out if I misspell O'Donnell's maneuver. I think I misspelled O'Donnell's. Check it. I think I have it. N-O-N-G. Can you check it? Can you check it for me, please? O'Donnell's maneuver. O'Donnell.
Yeah, O-D-O-N-O-G-H-U-E.
Oh, okay. O-D-O-N.
O-G. H-U-E.
Okay. H-U-E. Yeah. O'Donnell's maneuver. So this O'Donnell's maneuver, you use this test to differentiate between the muscle problem, joint problem. Yeah? So you differentiate between, I talked about this last week, right?
Yes.
So differentiate between the muscle and the joint problem, tendon and the ligament problem. Okay? So Barcode sign. Barcode is easy. Barcode. Arm up. So patient come in with the numbness, pain numbness to the hand, to the fingers. Arm up like this, make them feel better. Or you have a patient walk into your clinic, arm up like that, say, you know what, I'm so in pain right now. If my arm down, it hurt me more. Arm up, make me feel better. So you know this is indicate patient have some nerve root irritation. Yeah, cervical nerve root irritation. Why make them feel better? Because when I'm up like that, it relaxes the nerve. Yeah, my arm down, what happened? It's stretching out my brachial plexus, stretching out my nerve. So it hurt me more when with my arm down. Arm up, feel better. So this we call Barcode sign. Yeah, even patient will tell you, they will tell you that, you know, every time they, even nighttime when they lay down, they want to bring the arm up, make them feel better. Or some people driving, even driving, when they're driving the car, they like to bring the arm up because that will make them feel better. Okay, that's the Barcode sign. And then the cervical distraction. Cervical distraction test. This one, your patient lay down, sit, and you pull the head up. You pull the head up. Yeah. Distraction test. So head up when if you do distraction and they feel better. Okay, they come in with the pain and numbness, and when you do distraction, they will feel better. So that's indicate for the nerve root problem. Okay, and if I'm doing this on the patient and patient say, oh, it hurt me more, then maybe you might think patient may have some ligament muscle problem. Why? Because you're stretching out the joint, yeah, stretching out the muscle, yeah. So Burkitt is cervical distraction, and then the last one, the vertebral. I think I missed some spelling. Vertebral basilar artery. I think VERTE, not TR. Vertebral. Vertebral basilar artery insufficiency. So this test is supposed to be patient on the table, supine on the table, and you hold the patient neck, patient supine, the head is here, right? You hold patient's head, you rotate and you extend, yeah? Or you can do this test by similar with the maximal foraminal compression test. You ask the patient to rotate and extend. Okay, when patient rotate and extend and they feel dizzy, nauseated, vomiting, double vision, blurry vision, yeah, that indicate for a patient have a vertebral basilar artery insufficiency. What happens when they do like this? If they have stenosis inside of vertebral basilar artery, it will decrease the blood flow to your head, and that will make them feel dizziness, nauseated, vomiting. Okay, so that test I talked about this last week, right? You guys remember last week I also talked about this? People with the vertebral basilar artery insufficiency when they rotate and extend. Yeah.
I wasn't here.
You wasn't here. In the event from an Ortho last week, right? Online, right? And then you have to send out for MRA or MRI? Huh? MRA. Yeah. What MRA stand for? Magnetic resonance angiography. Yeah. So that one, they inject little dye into your blood and they capture the blood vessels. Yeah. Okay, so that is the vertebral basilar artery insufficiency. How this important? When you have the patient have a positive test, make sure after the treatment you don't do any tween or twisting, rotate, excessive cervical rotation on the patient neck, because that can cause a stroke. Okay, so when the patient have these conditions, or you don't have to do the test, patient will tell you every time they turn in the neck and they feel dizzy. So when they tell you that, you know that they had some issues inside the vertebral basilar artery. Okay, so that's it. That's the cervical spine. That's all the tests that I want you to know. So we'll practice later. Okay, and then shoulder. Shoulder is only 3 tests: empty can, speed, and junction. So empty can, you bring the shoulder between abduction and forward flexion. So 45 degree, thumb down, yeah? And then you put pressure on it and you ask the patient, lift it up. Let me borrow. And borrow your hand. Can you stand up? Go. Between the abduction, forward flexion, 45 degree, thumb down. Can you lift it up? I press down. Lift up. Yeah, there you go. Press down. Okay? So if he has a supraspinatus tendonitis, either you can feel he feel more pain, or the arm, this become weak. Yeah. So we call empty can or supraspinatus tendonitis. Empty can, that means pretend like I'm holding a can. I'm empty the can. You see that? Holding the can, empty the can. Yeah. Yep. And then you lift up and then you press down. This is the supraspinatus tendonitis. And then we have a supraspinatus tendonitis. Later you do the test, the needle. Supraspinatus, yeah, you do this point right here for me. Yeah, this point we practice needle. Earlier we in the class we already did this in the intern round, right? And then the speed and junction. The speed test is for bicipital tendonitis. Speed. Stand up. Speed. So from here, patient flex the forearm and I'll press down. So what happened? What happened during this maneuver? The bicep contracting. Yeah. And if he has a tendonitis here, inflammation of bicep tendon, it will hurt more, or become weak, or his arm become very weak when I do this. That's the speed. Junction. From here, Jurgensen from here. External rotate the forearm again with my pressure. Go. Go. So he tried to supinate and external rotate again with my pressure. You see this? Yeah. This one also tests for bicipital tendonitis. Yeah, because the function of the bicep was to flex the forearm and supinate the forearm. Yeah, the function of bicep. What is the function of bicep? Flex the forearm, supinate the forearm, and flex the whole arm. Okay, so the test, that is the Jurgensen. So empty can, speed, Jurgensen. Easy? Okay. And then thoracic outlet syndrome. There's many other tests, but this is the one that I want you to know. Roost. Come up and you open, close, and then after 30 seconds, the arm get fatigued and tired and drop down, or increase the symptom. Patient might tell you the arm up like that, they will feel more numbness, more weakness, more tingling on the hand, on the finger. So that indicates patient have thoracic outlet syndrome. What is thoracic outlet syndrome? Anybody know? What is thoracic outlet syndrome?
In the shoulder, right?
What is the thoracic outlet syndrome?
Is it the nerves being impinged?
Yes. So thoracic outlet syndrome is due to the compression on the neurovascular bundle. Neurovascular bundle. Compression on the basilar artery. Yeah. Subclavian artery and vein, and also the brachial plexus, especially on the nerve root, C8 and T1 nerve root. Okay, so let me review for you real quick on the thoracic outlet syndrome. Okay, this condition is patient has a symptom that manifests out to the hand, to the fingers. Either they have a numbness, weakness, yeah, or puffy hand, yeah, or cold hand, depend on the compression. If the compression on the artery, then patient might have some hand weakness, numbness, cold hand, yeah. If compression on the vein, they may have some kind of puffy, yeah, the hand become puffy, vein distensions, heaviness, yeah. If the compression on the nerve root, on the brachial plexus nerve root, like C8 and T1 nerve root, and most of the time 95% of the compression is on the nerve root. So C8, T1 nerve root, so they have a numbness, tingling numbness down to the pinky and ring finger. So what are the causes of the thoracic outlet syndrome? Okay, there's four causes of thoracic outlet syndrome. First, cervical rib. Cervical rib. So the rib number one, usually rib number one is come off from the transverse process attached to the transverse process of T1, right? But now people have a extra rib. Have you seen people have an extra rib? Huh?
I heard about it.
Yeah, extra rib. So that means the rib is instead of rib number one start from T1, right? Now C7. From C7 they have a elongate a little bit. The bone elongate now is at the transverse process. It's like look like a rib. Yeah, we call that an extra rib. Okay, or cervical rib, because cervical, that means it's elongate from the cervical transverse process. Okay, so that cervical rib can compress on the nerve, artery, vein, and that will make the symptom manifest down to your hand, to the finger, to the arm. Okay, that's the first thing. That can cause thoracic outlet syndrome. Second, thoracic outlet syndrome can cause by scalene muscle. You guys, have you guys learned to palpate the scalene muscle? Huh? No, never palpate the scalene muscle? Okay, this is scalene muscle. Look, this is your sternal SCM, right? From the SCM, you go from the posterior lateral, yeah? Posterior lateral. Do you see that little, from here, do you see that little muscle that's sticking out here? You press on it, that's where you're on SCM. Not SCM, scalene muscle. That's three parts of the scalene muscle: anterior, middle, and posterior scalene muscle. Yeah. So the scalene muscle tightness can compress on the subclavian artery, vein, or nerve root. And that can cause the symptom manifest down to the arm, to the hand, to the finger. Okay, that can cause thoracic outlet syndrome. Okay, and the third cause is the thoracic outlet syndrome is due to the narrow space between the clavicle. This is the clavicle and the first rib. See that space between the clavicle and first rib, but sometimes that space get narrow. Especially if any of you, like if you go hiking, yeah, you go hiking with heavy backpack on your shoulder, and when you hike up to the mountain, and then maybe after a few miles, you start have your hand, your finger, your arm become weak and numb. Why is that? Because probably the pressure. Yeah, you put too much pressure on the clavicle and the rib here, and that can pressure on the subclavian artery, vein, and your brachial plexus. So that make your hand become numb, become weak. Yeah, very discomfort. Okay, and then the last one is it caused by pectoralis minor tightness. Especially people have a bad posture, yeah, rounded shoulder, like this, and computer work for many years with shoulder forward, yeah, or people work in the people work in the gym, like work out too much in the front and shoulder move forward like that, and they will tell you that every time they work out, they feel like the arm get tired easily. Yeah, probably they work too much in the front, and that when the muscle become hypertrophy, it compress on the subclavian artery or the brachial plexus, and that makes symptom that manifest down to the hand to the finger. Okay, and then we have a test for that. So the rules, Edson, and the right test, and other tests. We have Halstead maneuver. You guys can look it up under my notes. Okay, in the previous class, the regular trial and Ortho, I have all that tests in there. But the one that I want you to remember, the rules, the right, the one that arm up will make it hurt more. So patient, you don't have to do the test, but patient will tell you on the OPQRST. Remember on the history, onset, provocative, palliative, QRST. On the provocative palliative, you ask them what make it better, what make it worse. Patient will tell you, the arm up, I feel more pain. Arm down, I feel better, right? Or every time I work out, or every time I arm up and down like that, I feel more numbness, more pain on my arm, on my finger. So that would be from the pec minor problem. Yeah, pec minor problem. You guys can look it up under my notes, thoracic outlet syndrome. We talk about it in there, right? Why is that? Because the pec minor underneath, the pec minor attached to the coracoid process, and underneath the pec minor you have a subclavian artery vein, the brachial plexus go underneath that. So people work in the stock room, arm up and down this every day, in the post office, yeah. Sometimes that can cause the pec minor tightness. So the rules test, you ask them to bring arm up and open, close, for maybe 30 seconds. Yeah, people get tired, the arm will drop. Okay, or right test, you palpate radial pulse, you lift the patient arm up, and then the pulse slowly diminish or absent. Or people start feel the hand get fatigued, tired. So that's probably they have a positive right test for thoracic outlet syndrome. Okay, and then Cozen. So what is the Cozen test? The Cozen is for a test for the tennis elbow. And then if you look over here, the tennis elbow, then we have to do the needle LI6, LI11 later. You guys practice that. You practice the test and you practice needle. Okay, stand up. Let me see can I borrow your elbow? Yeah. So this is the elbow. Stabilize the elbow. Make a fist. Okay, from here he'll extend the wrist. Again with my pressure. So what happened when he extend his wrist? His extensor is contracting. Yeah, and then his extensor is originate from attached to the lateral epicondyle. So if he has the inflammation on the lateral epicondyle, you expect he will have more pain. It will hurt more. Right here, hurt more here. Yeah? Or sometimes if you want more, you ask them to bring down like this. From here, extend. Now you put a lot more pressure on the lateral epicondyle. This is the Coulson test. Coulson test for the tennis elbow or lateral epicondylitis. Okay? Coulson. Phelan, reverse Phelan, finger stand, until now. Phelan, this is Phelan test. Phelan for carpal tunnel syndrome. So over here, carpal tunnel syndrome, we have a point for you guys for carpal tunnel syndrome. You guys do practice, yeah? So carpal tunnel syndrome, you do this, and that will increase the symptom. Patient will have more tingling, numbness down to the thumb, index finger, middle finger, yeah? You guys learn about carpal tunnel syndrome? The causes of the carpal tunnel syndrome, yeah? Okay, so I don't want to talk about it, okay? Save your time, okay? So carpal tunnel syndrome is affecting the median nerve, right? So the median nerve, the function of median nerve, it control the sensation, control the inside here, the thumb, index finger, middle finger, and half of the ring finger inside the palm, okay? So every time you have compression inside here, it will affect the sensory and also can affect the motor. The sensory, it will cause the numbness down to the thumb, index finger, middle finger, half ring finger. This numbness is 3 fingers. Especially numbness at night. Yeah? If patient come and say that I have a numbness at night, then you make sure you ask them which finger do you feel numbness. If they tell you that I have this 3 finger numbness at night, then maybe you relate that with carpal tunnel syndrome. Yeah? Carpal tunnel syndrome. Then you do the test. This is a Phelan. You press together, hold it for maybe 10-30 seconds. If that can increase the symptom, that is the positive for Phelan. This is the reverse Phelan. Reverse Phelan, aka Buddha prayer sign. Yeah, people go to the temple, pray for Buddha, holding like this for 10 minutes, 5-10 minutes, finger get numb. And they have to shake the hand. Again, hold this for another 10 minutes, hand get numb, shake, and then put it back like that. So this is the Buddha prayer sign. Reverse Phelan. Indicate for carpal tunnel syndrome. Yeah? And then Tinel sign, Tinel the percussion. Tinel, when you percuss any peripheral nerve entrapment, you percuss on it, it will provoke the symptom. Patient will have more pain that shooting down. Okay? So, Phelan, reverse Phelan, Tinel. Got it? Okay, and then the thoracic. In thoracic, we have Adam position. Adam position test is for people with the scoliosis. Yeah, especially if you have a kid at home and you want to test if your kid have a spine straight or not. You ask them to maybe with the usually you do this test for a woman. Maybe you put the gown on. Yeah, for the man, just take off the shirt and bend forward. When they bend forward, what happened? You stand from behind. Can you stand up here? Right. Pretend that he doesn't have a shirt on. Okay. So I'll stand from behind. First, stand up straight. Yeah. So out of position. I ask him to bend forward. Can you bend forward? So, and then from here, from this angle, I look for any deviation of his spine. One thing. Second thing, see if any bulging rib. Sometimes when he bend forward, one rib is bulging up like that, or his lumbar spine is bulging up this way. So that indicates he might have some scoliosis. Okay? Or at the same time, you can observe. You stand on this angle. You observe his shoulder height. Make sure it's the same level or not. Ear. And make sure it's same level, the hip, yeah, inferior border of the scapula. So when you observe the patient with when you do the test out of position, make sure they put a gown on, so that you can be able to observe on the back. Okay, all right, go ahead and stand here. Okay, and then the next one is Kemp test. Kemp test is almost similar with the maximal foraminal compression test. Rotate and extend. See, you remember maximal foraminal, rotate and extend. Kemp maneuver, rotate and extend. But this one, I want to do it. Look. Hold here. Stabilize here. I want to step back. Look, step back. I will rotate and go extend. Make sure he stand up straight, yeah? He doesn't bend his knee. Okay? So rotate, you okay? You okay?
Yeah.
Just like that. You not hurt?
No.
Okay? Same thing on this side. Look. Look. Stabilize the pelvic, rotate. Relax. Let me do it. You don't, yeah. Okay, there you go. You see this? So what happened? Let me get the spine. So can you get this spine on the back? So when you do that, what happened? You rotate and extend, you narrow the foramen on this side. You put more pressure on the facet joint on this side. And also you put more pressure on the disc on this side. If they have any problem on the disc, on the facet joint, inside the foramen, it will cause more symptoms. Patient might have the, you see this is where the nerve that coming out, yeah? From your spine, this is where the nerve coming out.
Yes.
Yeah, nerve root coming out, right? And this is where the facet joint. This is where the facet joint. This is where the facet joint, right here. Huh? And this is where the foramen. Yeah, foramen. And this is where it indicate for patient have a bulging disc, herniated disc. Yeah, this herniation. See, facet. Yeah. So look at the. This is where the facet joint.
I did everything.
This is where the and look at this right here. Yeah. Right. See the nerve root, the foramen.
We will do him last
The
time.
foramen where the nerve coming out, coming out.
Which?
So look. So his spine like this, right? So if you rotate, rotate and you extend. You see that? You extend. You put pressure on the facet joint here, on this side. So look, if I rotate and extend, so I put pressure here and narrow the foramen here. You see foramen? I'm gonna put more pressure on the joint. Yeah, from here, look, rotate and extend.
Yeah.
Yeah? You put more pressure on the facet joint, you narrow the foramen. Yeah, also you put more pressure on the disc. Normally, there's no pain, okay? If you hurt more, okay? For example, when I'm doing like this, and he said, oh, you know what, I have a swelling pain down to my, I feel the pain that's swelling down to my heel, to my ankle. So that indicates you have some nerve root problem. Yeah? Or when he doing like this and he said, oh, I have pain right here, localized pain, but it diffused down to my buttocks. So that also indicates he might have some facet joint syndrome. Okay? So localized pain, that's just the muscle problem. On the other side, right? The muscle problem, but the pain that localized, same side have been tested, that could be from the joint problem. Same thing with the cervical spine. Remember cervical spine, the maximal foraminal compression test earlier? Rotate and extend, yeah? So patient rotate and extend. What happened? Put more pressure on the facet joint right here. This is the facet joint. Yeah, this is where you see the facet joint. Yeah, this facet joint, yeah? And this is where the nerve root, yeah? And then the artery inside here is called vertebral artery. Yeah, when it go up, become basilar artery. This artery right here, yeah? Inside the foramen, rotate. So when you rotate the spine, also pressure on the artery. Yeah. If you have stenosis here, inside the artery, when you rotate and extend, it will limit blood flow to your head. Especially the blood circulation from here supplied to the cerebellum, the brainstem, cerebellum. Yeah. So what is function of cerebellum?
Voluntary movement.
Okay, and control your balance, yeah, coordination. That's what they will feel dizziness, yeah, losing balance, yeah. So because it's when you have a, and also this occipital lobe here, occipital lobe control what? Vision, vision, right? So if you have a limit circulation in your occipital lobe, what happened? Double vision, blurred vision. Okay? So, Kemp maneuver, Adam test, and the hip joint, Patrick Faber test. Patrick Faber, F stands for flexion, AB for abduction, ER for external rotation. So that means patient lay down on, we set up a table. Can we have a table?
I could bring it up there.
Yeah, please. So Patrick Faber test, you check for the hip joint problem. People with the hip joint, you do this test. If people have a degenerative or some hip joint problem, when you do this test, it will provoke pain. Okay, normally, if you have a normal hip, it won't hurt. But you have a hip joint problem, it will hurt you more. Okay, so this is Patrick Faber test. That means the flexion. This is flexion. Abduction. This is flexion, abduction, and external rotation. So I will lift the patient's hip up, flexion, abduction, and external rotation like that, and I will press down. Yeah. So. You guys learned all this test? No? Haven't learned this test before?
No.
How about any of this? No?
Video.
Huh? Some? Okay. Okay, yes, please. Patrick Faber. So, some patient, especially when they have a lumbar nerve root, upper lumbar nerve root, like L1, L2 nerve root problem, the pain sometimes can radiate to the groin, to the hip. Okay? So I want to make sure that. Sir, can you come over there?
Sure.
Yes, it's okay. You can do that after this one. No problem. Okay, so yeah. So I want to make sure that his hip joint. Patient come in with complaint of pain in the hip joint. Yeah? Pain in the hip joint can be from somewhere else, right? Like earlier, I told you that it could be from the lumbar nerve root, upper lumbar nerve root problem. Yeah? Or people have a psoas. Yeah? The iliopsoas problem also pain can go to the hip joint, the groin area. Okay? So this is the test that we do, the Patrick Faber test. First you want to rotate like that, yeah? Ask him if he have any pain. If it hurt, that means, there you go, he already have some hip joint problem, right? If he doesn't, so we do this. This is flexion, abduction, and external rotation. Faber stands for, F stands for flexion, AB stands for abduction, ER stands for external rotation. So from here, look, I'll press down, stabilize the pelvic and press down. And if it hurt inside the hip here, that indicates he have some hip joint problem. Okay? This is a Patrick Faber test. Got it? Okay. And then knee, valgus and varus. Valgus, okay? Valgus. So, look, his leg is heavy, yeah. Especially if you're a girl, right? It's so heavy. You cannot. If your hole is heavy, you cannot do the test. So what you can do? You put your knee, you rest his leg on it, yeah, like that. So you don't have to hold on it. So from here, look, valgus. Right, the joint. See my hand? I push this way. This hand I pull this. Valgus. That means valgus. I'm pull his out this way. So I check for the MCL. MCL stands for medial collateral ligament. MCL, okay? So, look. Make sure you don't extend all the way out. Yeah? Because if you extend all the way out, his knee is locked, then it's really hard for you to do assessment. Slightly flex, and then push. Okay, this is valgus. Valgus. Pretend. Same thing on the, let me see here. Valgus, same thing on the elbow. I check for the ulnar collateral ligament. Holding like that, valgus. See my hand? I bring his hand out like this way. I check for the ulnar collateral ligament. This is a valgus, and this is a varus. Valgus, varus. Yeah, it's okay. I'll show you later. Okay. And Lashman knee drawer test. So Lashman and knee drawer test is for ACL anterior cruciate ligament damage. And very common people with sport injury, soccer player, football player, skier can have an ACL rupture. Okay, so ACL rupture is very easy. You cannot miss it. You hold. This is a knee drawer test. Yeah, put like that, and you hold like that. You pull like that. No good knee, healthy knee, very stable. The knee with the ACL rupture, when you pull, you can feel the gap in or very loose. Yeah, pull like that. That's his ACL. Knee drawer test for ACL. Okay, and Lashman sentence. Lashman, you slightly flex about 15 degrees from this, and then you do the stabilize here. Pull up. You check for again for ACL. Lashman. Okay, check for the ACL. Knee drawer like this. Knee drawer. Lashman slightly flex, and then you pull. Okay, those tests is to test for the ACL rupture anterior cruciate. You guys know what is ACL? Yeah. What is function of the ACL? If you look at the inside the knee, inside the knee joint, the ligament like that, ACL on the top, PCL on the bottom. If you look on the front of my knee, see this is ACL attached like that. So the ACL prevent the tibia moving forward. Yeah, prevent my tibia moving forward. But if I have a rupture on ACL, what happens now? The tibia can move forward easily. So that's why when I do the test, I pull in forward. Yeah. People with the ACL rupture, very easy. When you pull, you can feel a big gap and very loose. Okay, that's the indicate for ACL. Look, ACL, and then you can do push PCL, ACL. Yeah. Okay. And then McMurray for meniscus. Okay. So look, I'm gonna do the external rotation of the foot. Put the valgus. Look. Out. Internal rotate of the foot. Valgus. Valgus. Yeah. Valgus. Valgus. Yeah. So with this one, I'm checking for meniscus. If he has some meniscus problem, when you do that grinding maneuver, it will hurt. Or you can hear like popping, clicking noise sound, or it will hurt more. McMurray test. Well, I believe that on this, the national board exam, they have a test McMurray. Remember, M for M, McMurray for meniscus. Yeah, McMurray for meniscus. Remember that. Okay, so McMurray. Yeah, see this? Look my hand. External rotate. Internal rotate. Come out. You see this? Okay, good. Okay, and then the ankle, knee drawer for ankle sprain. Yeah, ankle sprain, very common, right? So knee drawer. Can you go ahead and sit up? More easy. Yeah. It's okay. This one. So look, I'm holding on his calcaneus. Yeah, a calcaneus one put down on here, and I need pull like this way. Yeah, pull this way. So usually you test the ligaments for ankle sprain. On the outside, that's the ligament, anterior talofibular ligament. That's the 3 ligaments that usually when you sprain the ankle, you can rupture. And in that 3 ligaments, the one that most vulnerable for rupture is anterior, that means in the front. Anterior talofibular ligament. Talo, that means attached from the talus to the fibula. Yeah? So that ligament is vulnerable for injury. So when you do the test, just hold calcaneus from here. Look, you push. Yeah, you push like that. You check for the one hand push down, one hand you pull up for the anterior talofibular ligament. Okay, and then you can like this, or you can go reverse. You check for posterior talofibular ligament, or you can do inversion and eversion. Same thing. Yeah. Okay, so we finished all the tests. And the nerve root, I want you to remember all the nerve root. C5, C6, C7, C8, T1 nerve root. Thank you. Let me review for you real quick. So, nerve root upper extremities. We have a dermatome, myotome, reflex, right? Okay, dermatome. This is start from, if your hand in this anatomical position. Make your hand like that. Okay, start from C5. C5 dermatome, that means the sensory of C5. Control this part right here. C5. Yeah? C6. Go down to the thumb and the index finger. C7, middle finger. C8, the pinky and the ring finger. And T1 is right here. That's the sensory. C5, C6, C7, C8, and T1. So if patient come in have a severe numbness, pinky and ring finger, that is a C8 nerve root problem. Yeah? If you come in have a severe pinky and ring finger, C6. 5 here, upper.
Oh, sorry, yes, 6.
Okay, 6 is here.
Yes.
And this is very common. C6 nerve root compression or C6 nerve root lesion is a very common condition. Why is that? Because if you look at the spine, C6 foramen, between foramen where the C6 nerve root coming out is smaller compared with the top and the bottom. So people have a C6 nerve root compression is a very common condition. Okay? And they come in with the numbness, tingling numbness down to the thumb and index finger. Okay? So dermatome, C5, C6, C7, C8, and T1. That's finished dermatome. Okay, reflex. You have 3 reflex, C5, C6, C7. C5 is bicep reflex. C6, brachioradius reflex. Yeah? C7, tricep reflex. So when you percuss tricep reflex, the hand is jerking like this. You guys learned that in the physical exam? Yeah? Have you practiced in your physical exam? No.
No, I did not.
No. Okay, so remember 5, 6, 7. Okay? That's the reflex, and we're done. And then myotome. Myotome, that means control the muscle. Okay, for example, I do this. The main nerve root come to control this is shoulder abduction C5. Yeah? Also C5 doing this. Bicep flexion. Yeah? C5, C6, this is C5, C6. And then this is C6. Yeah? C7. C7, we call this is the wrist flexion. C7, tricep extension. C7, finger extension. C8, finger flexion. T1, finger abduction and adduction. So 5, 5, 6, 6, 7, 7, 7, 8, T1. Easy, right? So 5, 5, 6, 6, 7, 7, 7, 8, T1. Yeah, so you learn all that dermatome, myotome, dermatome, reflex. Yeah. Later, I'll show you how to do the testing those muscles. Yeah, when you do shoulder abduction, what you're looking for, right? Yeah. Always when you do the muscle testing, always do the good side first, and then you do bad side later, because then you can have a sense like how the, if the bad side have a weakness or not, right? You compare both sides, the strength of the both sides, the normal side and the healthy side and the bad side. Okay, and then also L1, L2, L3, L4, and L5, S1. This is the low extremities. Yeah, dermatome for L1. L1 dermatome is goes from the proximal of the thigh. Yeah, from lateral to medial to the groin area. So people have a L1 nerve root compression. Sometimes they'll complain, have a pain, numbness down to the groin. Okay? And then if you want to make sure a patient has any groin problem or not, or hip joint problem, do the Patrick Faber test. Do the Kemp maneuver. If I do Kemp maneuver and patient say, oh, I feel that pain going to my groin area, that's what you think for the nerve root lesion in upper lumbar. Yeah? So L1, L2, L3, distal of the thigh. So people with L3 nerve root problem, they have the pain, numbness on the distal part of the thigh, nearby the above the knee. Yeah, that's the L3. L4 on the middle part of the leg. Yeah, on the like spleen lever channel, on the middle ankle. So this is the L4. So if people come in and say, that, oh, you know what, I have pain, numbness on the middle, my middle ankle, on the middle part of my leg, think that could be from L4. Okay. L5 is on the anterior tibialis muscle on the stomach channel, stomach 36, 40, 41, yeah, to the big toe, second toe. Okay, and then S1 is more on the lateral ankle, on the gallbladder channel, on the UB channel, on the calf, yeah, to the small toes, bottom of the foot. Okay, do it again. L1, L2, L3, L4, L5, S1. That's the dermatome. Okay, so if I have a numbness, if I come in with a numbness on UB 59, UB 60, UB 64, 65, what is the possible diagnosis?
S1.
S1, yes, S1. S1, remember, S1 is on UB gallbladder channel. Yeah? Okay. How about if I come in have a pain numbness on my stomach 40, stomach 41 to my liver 3 area? What is possible diagnosis?
L5.
L5, yes. Okay, so that's the dermatome. Okay, and then reflex. The reflex. So L3, L4, patella reflex. So if you go to the doctor office, sometimes they percussion your patella. Yeah, you sit like that and they percuss both sides. Make sure you have a reflex response. Yeah. So reflex, when you percuss here, you can have either normal, yeah, or hyporeflexia or absent of reflex, or hyperreflexia. Especially when you have a hyperreflexia, that's it concern you, right? So people with hyperreflexia, like overactive, over reflex, right? So that indicate patient might have some central nervous system problem, brain down to the spinal cord. Might have some upper motor neuron lesion. Yeah, upper motor neuron lesion. That means they might have some, tumor in the spine. Yeah. Next time you have a stroke patient, for example, patient have a stroke on the muscle tightness on the right side, you just check the reflex. It's very hyper. Yeah, hyperreflexia. We call hyperreflexia. But people have a nerve root damage. When you check the reflex, it can be hyporeflexia or areflexia, absent of reflex. Yeah, so patella reflex is L3, L4. Yeah, mainly L4. Huh? Medial hamstring reflex, L5. Normally, we don't test that medial hamstring reflex. We do the patella or Achilles tendon. Achilles tendon reflex is the S1. That's it, right? Reflex done, right? Okay, and then motor. So 1, 2, 3, lift the knee. That means L1, L2, L3, lift the knee. Help me to lift the knee. 1, 2, 3, lift the knee. Yeah, easy, huh? L3, knee extension.
Soccer.
Yeah, knee extension. L3, knee extension. Okay, L4, dorsiflexion foot. See, this is dorsiflexion of the foot. L5, dorsiflexion big toes. S1, plantar flexion. That's it. So you ask the patient you test for the L3, L4, or L1, L2, L3, squatting up and down. Yeah. If they say, oh, you know what, I feel my quad on this side so weak. When I squatting up, I feel so weak. So that means they might indicate they have an L3 nerve problem. Yeah. Or you ask them, can you walk on your toes? Walk on your heel? See, I can walk on my heel, right? But people have severe L4, L5, especially L4. You walk on this side, and this side cannot lift it up, drop like that, like this. Yeah, they can walk only one side. The other side, the side that they have a problem, they can walk on the hill. So that means indicate patient have an L4, L5 nerve problem. Okay, or you test them. You ask them, walk on the toes. See, I can walk on my toes, right? But if I have some S1 nerve root involving with the motor deficit, I won't be able to walk on my toes on the side that I have a problem. So, okay, got it? Easy? No? Okay, L1, L2, L3, dermatome. L4, L5, S1, right? Reflex, L3, L4, L3, L4 reflex, L5 reflex, the medial hamstring reflex, S1, Achilles tendon reflex. Okay? For the motor, L1, L2, L3, lift the knee. L3, knee extension. L4, dorsiflex of foot. L5, dorsiflex of big toes. S1, plantar flexion. That's it. You want to test that? Squat in, walk on your heel, walk on your toes. Hip flexion, press down. You ask the patient to flex the hip, you press down, you check for the L1, L2, L3. Kick the knee out with the resisted. Come up here. Come here. Come on. 2 more minutes, we'll take a break. Yeah, you want to take a break or you know? Okay.
A short one.
Okay. So, L1, L2, L3. Can you bring the hip up? Yeah, good. See that? I press down. Can you bring this one up? I press down. Okay? Can you kick out? Knee extension. This. What? This is what? L3. Yeah? L3. He kick out, I press down. Yeah? Can you dorsiflex of the foot? He dorsiflex, I press down. You see? Yeah? Or you can stabilize his foot, dorsiflex it. Yeah, like that. Make sure you isolate. You don't allow him to use the. You know, some people, because they have a weak on the dorsiflexion of the foot, what they do, they use the quad. Yeah, so you isolate that part. Just pull here, and you dorsiflex. There you go. Or let him walk on the heel. Okay, same thing, plantar flexion, he press up, press up. Thank you. Okay, all good? Everything, I'll review for you all the tests already. You can later practice needle. The one that I want you to practice needle on the face, because a lot of people don't feel comfortable with needle on the face. So this is the Bell palsy. You will see a patient come in with Bell palsy. And then if you're afraid of needle on the face, then you cannot treat the patient. Okay? So later I want you to practice those points. See the point that I highlight like this? From connect this point to this point, 14 to GB8, that means I hook up that with electrostimulation. Yeah, GB8, GB14, hook up this one channel with, yeah? Stomach 3 or stomach 2. Stomach 2 right at the infraorbital. Yeah, stomach 3 is right on the nostril, right? Right on the nose. Yeah. So this one hook up with stomach 7. So you take care of this part, you take care of this part, and then stomach 4. Stomach 4 instead on the side, but I want to insert from inner the corner, inner the mouth. From inner the mouth, inside the mouth as a corner, and you thread into the stomach 6. Yeah, you 1.5, it's okay, 1.5 or 1 2 needle threading this way, and then stomach 6. If you clenching your teeth, when you see that muscle that pop up, the masseter, that's where you the stomach 6. Okay, so stomach 4 with stomach 6, another channel. So what 3 channel? I want to needle those points and practice. Okay, take a break. Let's take a break.
You want to stop it?
You have any question? You can ask me now.